everyone, welcome to the class of orthopedics. बहुत बहुत स्वागत है सबका. And I know that you are super excited and you have promised, first of all, a very happy new year to all of you. Okay, happy new year 2026. And this is our first class of 2026, and I'm so happy that I have got a set of beautiful and lovely hearted, hardworking students with me. Okay, so happy new year to all of you, and we will start with the orthopedics class. I know we are already late 15 minutes because of some technical errors that we got, and still I can see those technical issues in front of me. So okay, होते रहेंगे यार, वो सब सॉल्व होता रहेगा धीरे धीरे. Okay. So, as you all must be knowing that it's a very new initiative by us. We, the members of Med Academy, are proud to, start this new initiative, that is the university exam. Okay, so I know that like with due respect to all the professors out there in your colleges, see what happens is that they are in a habit to teach a lot of things, but the problem is the more stuff you have, the less you are going to retain. जितना ज्यादा पढ़ोगे उतना ज्यादा भूलोगे. Why? Because there is a component which gets missed always, and that is called as revision. So इसीलिए बहुत important बात है कि क्या पढ़ना है वो important आपको पता होना चाहिए, that what you are supposed to read. Okay, and once you are available, once you are aware of what you are supposed to read, of course you can do its revision multiple times, and whatever you read you can retain it. ठीक है, तो इसीलिए ये जो सेशन है, ये जो सीरीज है, ये मेड अकेडमी की तरफ से जो सीरीज है, ये आप लोगों को इसी चीज से अवगत कराने के लिए है कि क्या चीज इंपॉर्टेंट है एग्जाम पॉइंट ऑफ व्यू से और क्या चीज नहीं है. तो इससे पहले कि हम आज की क्लास स्टार्ट करें, कुछ एक क्वेश्चंस मैं आपसे पूछूंगा, बिकॉज नाउ अ डेज व्हाट आई एम ट्राइंग टू टेल यू एंड व्हाट आई एम ट्राइंग टू सी इज that lot of questions are not directly asked. The questions have turned as one liners, not one liners, I should say clinical based. Okay, clinical based, clinical scenario based. Okay, and because they have turned clinical scenario based, that's why I've incorporated some clinical scenarios, so that first of all you'll be able to diagnose the condition, and once you are able to diagnose the condition perfectly, the second thing what you are supposed to do is to write a long question or a short note on that. Okay, so for example, this first question: a 22-year-old male recruit complains of gradually increasing foot pain after prolonged marching. So this is something which they are going to give you, and marching turns out to be the keyword in this. Okay, एक 22 साल का आर्मी का बंदा फुट पेन हो रहा है, इंक्रीज हो रहा है प्रोलॉन्ग मार्चिंग के बाद, और एक्सरे शो करता है अ हेयरलाइन फ्रैक्चर ऑफ द सेकंड मेटाटार्सल. So if this is something which is given, a second metatarsal hairline fracture, then you have to understand that this is nothing else but what is the diagnosis? The diagnosis is March fracture. ठीक है, मार्च फ्रैक्चर जो है वो डायग्नोसिस हो जाएगा. ओके, सो व्हाट इज गोइंग टू बी द डायग्नोसिस? द डायग्नोसिस इज गोइंग टू बी व्हाट? दैट्स गोइंग टू बी मार्च फ्रैक्चर. एंड मार्च फ्रैक्चर में द थिंग इज इंपॉर्टेंट इज that the second metatarsal is something which is involved. Okay, so in March fracture, first of all, M for March and M for your metatarsal. Okay, metatarsal. So metatarsal is going to get involved. Okay, now first or second, तो just ऐसे समझो कि first thumb होता है, थंब है थोड़ा बड़ा है, तो बड़ा है तो उसको ज्यादा परेशानी नहीं होती, बट ये जो सेकंड वाला है ये जल्दी से टूट जाता है. सो दिस इज द सेकंड मेटाटार्सल व्हिच इज इन्वॉल्वड इन द मार्च फ्रैक्चर. ओके, coming on to next question. The next question is, yes, so what is the next question? The next question is this: a 35-year-old diabetic patient, understand, a 35-year-old diabetic patient who presents with the chronic pain and discharging sinus. Okay, okay, so a 35-year-old diabetic patient who is presenting to you with a chronic pain. There's a chronic pain in this patient, and there are some discharging sinuses from the leg. Okay, from the leg, following an open fracture 6 months ago. Okay, जिसको क्या हुआ था? एक open fracture हुआ था 6 months पहले. X-ray shows a dense separated piece of dead bone which is surrounded by a radiolucent area. What is the diagnosis? So of course it's a osteomyelitis, that's the diagnosis, but what they are trying to ask you, what they are going to, osteomyelitis is एक important topic है. Osteomyelitis हम लोग पढ़ेंगे naturally थोड़े टाइम के बाद, आने वाले subsequent sessions के अंदर में हम लोग जरूर पढ़ेंगे osteomyelitis के बारे में. बट अभी हम लोगों को क्या डिस्कस करना है, क्या समझना है, वो ये है कि इस लेक्चर में हम लोग को क्या पढ़ना है, इसी के सिक्वेस्ट्रम के बारे में. So what is sequestrum? Sequestrum is a dead necrotic bone. Okay, it's a necrotic bone. So the people who have joined, I request you to type in the comment section the answer of this. A 60-year-old woman with a history of breast carcinoma presents with a thigh pain after trivial trauma. X-ray shows fracture through lytic bone lesions. Okay, X-ray shows fracture through lytic bone lesion. This is which type of fracture? Of course, that's a fracture. No doubt it's a fracture, but it's which type of fracture? Chaliye, 5-6 people have joined. I want you to write down in the comment section quickly. Okay, write down in the comment section very quickly which type of fracture is it? Anji, which type of fracture is it? So it is a, yes, it is which type of fracture? It is pathological fracture. Why it is pathological fracture? Because already the pathology was existing and this fracture happened in that pathology. What was the pathology? Pathology was the metastasis from the bone. Okay, so bone mets were there and that causes pathological fracture. Coming on to the next question, next important part. 28-year-old man who presents after a road traffic accident with pain, with swelling, with deformity of the right leg. X-ray shows break in the continuity of the tibial shaft. What is the diagnosis? Nothing but a fracture. Okay, nothing but a fracture. So this kind of questions they can ask you. What is the diagnosis? And in the next part, in next question they can ask you about the definition, about the stages, about the different types. Okay, these kind of things. Coming on to the next question, 7-year-old child falls while playing and presents with pain, swelling. Okay, so that's why, see, understand, and आगे लिखते हैं, X-ray shows fracture of one cortex with bending of the opposite cortex. So, for example, this is the intact bone. Okay, this is the intact bone. Okay, and for example, if the one part gets fractured and the other part is, is bowing inside, okay, like this, okay, like this, okay, so one part is fractured, another part is bowing, so this is called which part, which fracture? This is called as Greenstick fracture. ठीक है, इसको हम कौन सा fracture बोलते हैं? This is called as Greenstick fracture. Okay, this is called as Greenstick fracture. Okay, so all these were the different questions. All right, different questions, and of course these are our topics for today as well. Okay, topics for today's as well. So first of all, I will take this question. Okay, first of all, I'll take this question. I think I have, where's the question? Just one second. Fracture, yeah. So first of all, I'll take this question. A 28-year-old man presents after a road traffic accident. Okay, so this is what we are going to discuss at first. These are the different images which I'll show you after the end of the class, because sometimes they can ask you the image based questions as well. So a 28-year-old, yes, so I just told you that break in the continuity of the tibial shaft, and if they ask you the diagnosis of that, the diagnosis is going to be what? The diagnosis is going to be fracture. Okay, that's going to be fracture. So in fracture, what are the possible questions they can ask you? So they can ask you like this. If they want to make a long question, they can ask you like this. So they will ask you, define fracture. Then they'll ask you what are the stages of healing of different type of fractures. Okay, stages of healing they'll ask you. Then they'll ask you what are the different types of fracture. Okay, types of fracture they can ask you. Then immediate and delayed complications. Immediate and delayed complications. Okay, so immediate and delayed complications they can ask you. Okay, so these are the important points which they can ask you regarding the fracture. Okay, so let's just quickly one by one try and understand about all these things. So let's discuss about the fracture topic now. So topic one, that is fracture. Okay, so topic one, and that is fracture. Okay, so what is the definition of fracture? क्या होता है definition, क्या होता है fracture का? Yes, definition of fracture is it is the break in continuity of the bone. Okay, so definition wise it says that it is a break in the continuity of the bone. Okay, continuity of bone. So break in the continuity of the bone is called as fracture. It is called as fracture. Coming on to the types of fracture. So what are the different types of fracture? I have got a beautiful image for you. I'll try and show you the different types of fracture, bone fracture. Okay, so I'll take this image and here I'll keep this image to show you the different types of fracture. Okay, yes, so here are the different types of fracture. So if you look at the different type of fracture, just know that if the fracture line is perpendicular to the axis of the bone, so this is the axis of the bone and this is the fracture line. So if the fracture line is perpendicular to the axis of the bone, it is called as transverse fracture. Okay, so if the fracture line is, okay, I'll write about the transverse fracture. So what is transverse fracture? If the fracture line is, okay, just one second, yeah, so if the fracture line is perpendicular to the long axis of the bone, it is called as transverse fracture. It is called as transverse fracture. Okay, I'll write down the next point now. I'll write down the next point. So this is the transverse fracture. Okay, now I'll write the next point. If the fracture line is along the axis of the bone, then what will you call it as? Yes, yes. So Anna says how we should be doing sessions currently from main notes MCQ based mode. See beta, this is something that can give you the MCQ's answer as well, because can you understand, can you see this? This is how I'm telling you MCQ wise as well. So if the fracture line is along the axis of bone, very good Navneet Kumar, it is called as linear. It is called as linear fracture. It is called as linear fracture. Okay, so can you see here we have, yes, see here, here we have the linear fracture. Linear if the line is along the axis of the bone. Just one second. Hello, Hanji. Okay, so this is called as which fracture, bache? Linear fracture. Coming on to the next one, this is oblique fracture and which is not displaced. So oblique fracture which is not displaced. Here you can see the oblique fracture which is displaced. Oblique fracture which is displaced. And what is this? This is spirally. Okay, spiral. So can you see? This is spiral. So here you will see the fracture. Here you will see the fracture. Here you will see the fracture, but in different. Okay, so but in different planes. So spiral fracture is having the, okay, what is spiral fracture then? Spiral fracture is the fracture which is in more than one plane. So fracture in more than one plane. Okay, fracture in more than one plane. Okay, yes, fracture in more than one plane. So one in more than one plane means, of course, it's going to be spiral fracture. What about Greenstick fracture, which is itself a question for us? What is Greenstick fracture? So, bache, Greenstick fracture definition says that if one cortex, can you see here? So this cortex, one cortex is going to be bent. Okay, one cortex is bent. One side of the cortex is bent, and the other side is fractured. Okay, other side is fractured and other side and one side is actually bent. Okay, so this is something which is called as Greenstick fracture. Now what is comminuted fracture? Where the fracture is responsible for, where the fracture is responsible for for formation of multiple pieces. Okay, where fracture yields multiple pieces of bone, it is called as comminuted fracture. It is called as comminuted fracture. So you can see which type of fractures: transverse, linear, oblique, spiral. Okay, green stick, comminuted. Okay, green stick and comminuted. So you can remember with the mnemonic green salt. Okay, green salt. Okay, green salt. Okay, and from if everything is gone, then of course like how अगर आप salt देखो तो कैसे होता है, बिखरा बिखरा सा होता है ना multiple pieces में. So this is how you can remember the comminuted fracture. Okay, comminuted fracture, not comminuted, it is called as comminuted. Okay, comminuted fracture. So this is how you can remember the types of bone fracture anatomically. So I am trying to tell you about the types of bone fracture, and this was the first classification, which is based upon, yes, which is based upon the anatomical. Okay, anatomical basis. Okay, so this is how you can remember about the anatomical basis. Coming on to the next part is something on the basis of etiology. So if I go by the basis of etiology, on etiology we have two types, so three types rather. Okay, now your time, you will tell me. Okay, for example, if there is underlying disease, which type of fracture is called? Okay, if there is underlying disease, which is this fracture? Okay, for example, A fracture is the one which is having the underlying disease. Quickly tell me which fracture is this. Next is if it is having a chronic repetitive injury, then which type of fracture is this? And if they have a direct hit, okay, a direct hit, then which fracture is this? Okay, direct hit is nothing but a traumatic fracture. It is a traumatic fracture. Whereas the chronic repetitive injury is called as which fracture? Chronic repetitive injury is called as which fracture? Stress fracture. Okay, it is called as stress fracture. And if there is an underlying disease, then it is which fracture? Then it is called as pathological fracture, because an underlying pathology is there. Pathological fracture. So this is something which is etiology based. After that, you have got on the basis of displacement. Okay, on the basis of what? On the basis of displacement. So on the basis of displacement, we have got two types broadly. One is undisplaced fracture, where it is not displaced, and the other is called as displaced fracture. तो displaced fracture का क्या मतलब होता है? Displaced fracture का मतलब होता है that we have to understand कि displacement हुई तो कैसे हुई. For example, if one part is like this, other part is like this, so you can just see that it has shifted a little. So it is called as shift in the displaced fracture. Very good, Navneet Kumar. So it is the shift in the displaced fracture. But for example, if the two bone fragments come at these angle, it is called as which fracture? Bachche? Angular fracture. It is called as which fracture? Angular fracture. And now, if I just try and show you like this, okay, if I try like two fragments are like this, and this fragment is rotated, this is called as which fracture? This is called as rotational fracture. Okay, so remember like this: shift fracture, angular fracture, rotational fracture. So these are the displaced fracture or displacement fracture like this. Coming on to the next important part, what is the relationship with the external environment? Okay, what is the relationship with the external environment? Okay, so relationship with the external environment. So what is the relationship with the external environment? Either it is going to be closed fracture or it is going to be an open fracture. So if it's a closed fracture, of course there will be an overlying, yes, there will be an overlying skin, or there will be an overlying soft tissue which is going to be there. Skin or soft tissue is going to be there. Very good, bacha. And then open fracture, two types: externally open fracture, internally open fracture. So if it's an externally open fracture, of course the skin is going to be damaged, and if it is an internally open fracture, that means the soft tissue is something which is damaged. Okay, soft tissue is something which is damaged. After that, you have got next part about the complexity. Okay, so this is about the relationship with external environment. Now we will talk about the complexity of the fracture. Complexity of the fracture. So complexity, yes, on the basis of complexity, tell me कौन से type के fracture होते हैं? हाँ जी. So on the basis of complexity, either it is going to be a simple fracture where you have got two fragments. Okay, so if you have got two fragments, it's a simple fracture. Whereas if you have got multiple fragments, okay, if you have got which what fragments, multiple fragments of agar hain, then it is called as, it is going to be a compound fracture. Very good, swingy mood Sejal, very good. It's a compound fracture. Very good बच्चे, God bless you. Good, very good. तो देखो, इसी तरीके से मेहनत करते रहोगे, सो ऑफ कोर्स यू आर गोइंग टू हैव गुड मार्क्स, गुड ग्रेड्स. आदत हो जानी चाहिए काम करने की, ठीक है. यू शुड बी हैबिचुअल ऑफ वर्किंग, बिकॉज दिस इज अ वेरी गुड सेइंग, खाली दिमाग शैतान का घर. ओके, coming on to the quantum force. Okay, coming on to the quantum force. Quantum force means either it's a high velocity or it is a low velocity. Either it is a high velocity or it is a low velocity. Now all these things are actually important, but what happens with most of the students, they just forget कि सर हमें याद रखना था बट हम याद नहीं रख पा रहे हैं. ठीक है, याद रखना था बट हम लोग इसको याद नहीं रख पा रहे हैं कि हम लोगों को, कि हम इसको याद कैसे रखें. ओके, सो जस्ट रिमेंबर C for complexity and, yes, C for complexity, D for displacement. Okay, I'll write C for complexity. One second. C for complexity, D for displacement, E for etiology, E for external environment, F for force. Okay, and B and A for anatomical, and B for break in the continuity. That means your nothing but your fracture definition. So this is how you can remember A, B, C, D, E, F is the mnemonic to remember the different fractures types. Okay, A, B, C, D, E, F, A, B, C, D, E, F. Just one second. A, B, C, D, E, F. Okay, so this is the mnemonic to remember different types of fracture. Okay, different types of fracture, right? Now it's easy. Very good, Navneet. So this is the mnemonic to remember the different types of fracture: anatomy, complexity, displacement, etiology, external environment, force. Okay, so this is the very good and important trick to remember. Okay, coming on to the next part, बच्चे. Coming on to the next part. So ये एक चीज हमने पढ़ी है अभी के लिए. The definitions we are done, and then type of fracture also we have discussed. Okay, now इससे पहले हम लोग बात करें about the stages of healing and immediate and delayed complications. I want to teach you another thing. देखो बच्चे, अब जो मैं आपको चीज बताने वाला हूँ ना, ये आप सिर्फ हमारी क्लास में ही सीख सकते हो. जैसे मैंने आपको कहा that you should know this much but you should write this much. Now how it is possible? See, for example, if a question comes to you, okay, I'll give you the question, just give me 1 minute. If the question comes to you, for example, as I've given you the question, no, that a 60-year-old woman who was suffering from breast cancer, and this question. Okay, this question. So 60-year-old female who was suffering from breast cancer, she had the fracture in an area where there were some, yeah, so X-ray shows fracture through the lytic bone lesions. Okay, so there is a fracture along the lytic bone lesions, right? So this question is pathological fracture. Okay, now what happens is, होता क्या है कि जो आपके प्रोफेसर्स भी होंगे ना बेटा, वो आप लोगों को पढ़ाते हैं कुछ इस तरीके से कि जैसे फॉर एग्जांपल इफ दे आर टीचिंग फ्रैक्चर, ठीक है, तो वो फ्रैक्चर में ही आपको स्टेजेस ऑफ हीलिंग बता देंगे. ठीक है, स्टेजेस ऑफ हीलिंग बता देंगे. उसी फ्रैक्चर में आपको उसकी कॉम्प्लिकेशंस भी बता देंगे. ठीक है, बट जब वो मान लो पैथोलॉजिकल फ्रैक्चर बता रहे हैं, जब वो पैथोलॉजिकल फ्रैक्चर बता रहे हैं, तो वो फिर स्टेजेस ऑफ हीलिंग और कॉम्प्लिकेशंस का जिक्र ही नहीं करते. अब ऐसा थोड़ी है कि जो पैथोलॉजिकल फ्रैक्चर है उसमें हीलिंग नहीं होती, हीलिंग तो उसमें भी होती है। तो स्टेजेस ऑफ हीलिंग तो यहाँ पे भी लिख सकते हैं हम लोग, कॉम्प्लिकेशंस तो यहाँ पर भी लिख सकते हैं। इसीलिए जो मेरी क्लास है ना बच्चे, उसके बाद आपको समझ में आएगा कि हाउ टू एक्सपैंड योर आंसर। ओके, सो फॉर एग्जाम्पल सम डे दे आस्क पैथोलॉजिकल फ्रैक्चर इन 10 मार्क्स एंड यू आर लाइक यार ये 5 नंबर के लिए तो पढ़ा था, 10 नंबर में क्या लिखे? सो ऑफ कोर्स हीलिंग यू कैन राइट, ऑफ कोर्स कॉम्प्लिकेशंस यू कैन राइट। तो ये सारी चीजें भी जो है ना आप लोगों को समझ में आती जाएंगी कि हम और एक्स्ट्रा क्या लिख सकते हैं। इसीलिए हमने फ्रैक्चर का डेफिनेशन पढ़ा, हमने फ्रैक्चर के टाइप्स पढ़े। अब हम एक दो टाइप्स को एक्सप्लेन कर देते हैं और उसके बाद में हम लोग पढ़ेंगे स्टेजेस ऑफ हीलिंग एज वेल एज कॉम्प्लिकेशंस। ठीक है, स्टेजेस ऑफ हीलिंग पढ़ेंगे और उसके बाद में हम लोग कॉम्प्लिकेशंस भी डिस्कस करेंगे। ठीक है, तो चलिए अब हम टाइप्स ऑफ में ही पढ़ रहे हैं तो एक दो टाइप्स जो है हम अच्छे से थोड़ा सा डिस्कस कर लेते हैं। सी है, so this is nothing else but a pathological fracture. ठीक है, this is a pathological fracture. So let's discuss about the pathological fracture. So pathological fracture में भी सेम आपको पढ़ना है। सबसे पहले pathological fracture की definition, and it's always a good idea. It is always a good idea. Like whenever you're writing some answer, it's always a good idea to have टू राइट इट। ऐसे लिखो कि पैथोलॉजिकल फ्रैक्चर है तो मैं उसमें क्या क्या बताने वाला हूँ। आई एम गोइंग टू टेल यू द डेफिनेशन, आई एम गोइंग टू गिव यू द कॉजेस ऑफ योर पैथोलॉजिकल फ्रैक्चर, then we will have the diagnostic part. Okay, diagnostic part, then we'll have the clinical features, and then we'll have the diagnostic part also, then we'll discuss about the treatment. Okay, about the treatment. ठीक है, so this is something which is important in the pathological fracture. Okay, pathological fracture. Chalo, so let's quickly start with the pathological fracture. What is the definition of pathological fracture? So this is the second topic we are starting with, that is pathological fracture. So coming on to the definition of pathological fracture. Hanji, coming on to the definition of pathological fracture. So a fracture, okay, a fracture which occurs in a bone which is made weak because of some underlying disease. Okay, so fracture which occurs in a bone which is made weak because of some underlying disease is the definition of a pathological fracture. Okay, definition of a pathological fracture. Coming on to the causes. Coming on to the causes. So for causes, the mnemonic is coins. Okay, the mnemonic to remember the causes of pathological fracture is coins. C for it is going to be congenital. Okay, congenital. O for obstruction. I for inflammation. N for neoplastic. And S for some systemic disease. S for some systemic disease. So congenital, yes, what can be the congenital cause of pathological fracture? It is osteogenesis imperfecta. It is osteogenesis imperfecta. What about the obstruction? So for example, if there is a obstruction or a cyst kind of a thing, okay, cyst like simple bone cyst, okay, simple bone cyst. So it is going to obstruct the space. Now, for example, this is the normal bone, and if you have a expanding cyst over here, so it's going to obstruct the part. Okay, so simple bone cyst. Okay, then you have got inflammation. So inflammation, osteomyelitis. Okay, so inflammation, osteomyelitis. Then neoplastic. Now neoplastic can be benign or can be malignant. Okay, can be benign or can be malignant. Okay, so if it's benign or if it can be malignant also. Chalo, so benign and malignant. Benign like giant cell tumor, giant cell tumor, or you can have enchondroma. Enchondroma. So remember, giant cell tumor and enchondroma, both of them are benign. Whereas like osteosarcoma and you have got Ewing's sarcoma, these are malignant, because you know by the basic knowledge of your pathology, anything which is having sarcoma or carcinoma is going to be malignant. And there are some systemic diseases also, like rickets, like scurvy, like your osteoporosis or your osteomalacia or Paget's disease or multiple myeloma. Okay, multiple myeloma. Okay, so these kind of things you can remember. So MNOPQRST. So P for Paget's disease. Okay, P for Paget's, M for multiple myeloma, then O for osteoporosis, then then osteomalacia, then QRS, R and S for what? R for rickets, S for scurvy. So this is how you can remember very easily. Okay. So this is the different causes. Okay, pathological fracture, these are the different causes of pathological fracture. Okay, so coming on to the next part, that is, okay, now this is an MCQ. So some people were asking, sir, how to prepare for MCQs. So coming the MCQs, what is the most common cause of pathological fracture? Yes, quickly tell me, what is the most common cause of pathological fracture? So by the time you give the answer, I'll come on to the diagnosis part. I'll come on to the diagnosis part. So no answers. Okay, bache. Most common cause of pathological fracture is going to be what? That's going to be osteo what? Now to tell me, osteoporosis or osteomalacia? Yes, tell me, osteoporosis or osteomalacia? Osteoporosis. Okay, osteoporosis. Coming on to the diagnosis part. Now, first of all, in diagnosis, what is most important is going to be the history. Okay, history. Okay, history. So how history? For example, again, so first point is history basis. Okay, so pathological fracture, history is something really important. So let me just tell you, COINS. Okay, and first of all, history should not have trauma, because if it is trauma, of course, see, if it's a trauma, you need not ask the history. Okay, but if there's no trauma, then history becomes very important. So for example, if it is congenital, then it is, of course, they'll tell you it is present since birth. Okay, if this something obstructive, just like I've told you, swelled part, swelling part, then it is going to be what? It is going to be swelled part, then it's going to be a cyst part, then it's going to be a simple bone cyst. So cyst will show you what? It will show you swelling. Coming on to eye is actually inflammation, or eye, you can tell about the infection and inflammation. So the signs of inflammation like fever, like redness, okay, all these things are going to be there. Then of course neoplastic, so signs of cancer, signs of neoplasm are going to be there. Okay, like the weight loss is going to be there, like the anorexia is going to be there. Okay, so weight loss is going to be there, anorexia is going to be there. Then the systemic. So systemic means what? Like for example, if she's an old age female, so that's going to give you the hint of like yes, osteoporosis. Then if for example bowing of legs, hint, bowing of legs. Okay, so if you have the hint of bowing of legs, what is the diagnosis? If there is bowing of legs, what is the diagnosis? Next we have, okay, answer is rickets. So next we have the age group now. Okay, the age group. So what is important when it comes to age group? So in age group, bache, please understand, it can be like at birth, then 5 years of age, then 20 years of age, 50 years of age, okay, and more than 50 years of age. So for example, if we ask about the at birth, then conditions can be like congenital osteogenesis imperfecta, okay, osteogenesis imperfecta. Then at 5 years there can be rickets. At 20 years you can have some malignancy also, malignancy in young patients like Ewing's sarcoma. Okay, then 50 years you have got Ewing sarcoma or a giant cell tumor. Ewing sarcoma or a giant cell tumor. And if it comes to more than 50, it is osteoporosis. Okay, osteoporosis, right? So, these things are really important, and keywords also. So somebody was asking, sir, MCQs, MCQ में क्या important है? How can you help us with the MCQs if we study these sessions? ये important है. For example, there is an old lady. Okay, for example, there is an old lady, and in this old lady, you have got history of chemotherapy. Okay, history of chemo, history of radiotherapy. Okay, right, you got it. So which type of fracture it is? Pathological fracture, naturally, because she has underwent these things, your chemo, your radio, right? So chemo has been done, radiation therapy has been done. So of course, in this patient, what you have to understand, that it must be a bone metastasis. Bone metastasis. Now, this is something which is important if it comes to a MCQ question. Which fracture, I mean, which bone tumors, which tumors have their metastasis into bone? ठीक है, तो बोन में कौन से ट्यूमर्स की मेटास्टेसिस आती है वो आप मुझे बताओ. ठीक है, कोई एक भी लिख दो, आई विल बी वेरी हैप्पी. राइट एनीवन, आई विल बी हैप्पी. So just remember my name starting from P and L. So P for prostate. Okay. Prostate and lungs in case of males are very common. And when it comes to females, females also have lungs, and of course breast. Okay. So breast and lungs are very common in females. So breast, lungs, all these cancers have a common tendency to get metastasized into the bone. Into what? Into the bone. Okay. So coming on to the last part of this pathological fracture, and that is the treatment. Okay, that is what? That is the treatment part of the pathological fractures. Treatment part. So in treatment, just understand, one is osteogenesis imperfecta. So for example, if there is the underlying condition is osteogenesis imperfecta, what treatment you are going to give? So you have to supply the connective tissue in this patient. Okay, they don't have connective tissue, so supply the connective tissue. Then if there is osteomyelitis, then what you will do? See, I am trying to tell you all these things. Otherwise, I would have written, okay, treat the cause. But that is not going to solve the purpose. Okay, and many a books they write treat the cause, but my examiner wants some detailed explanation. Okay, so in osteomyelitis, what you will do? Price therapy. What is price therapy? You will give painkillers, you will give rest to the patient, you will do icing, then you will give the cold compression also. Okay, rest or immobilization, you can remember immobilization. Then you're going to give cold compression. Then what does E stands for? E for elevation. Okay, so these are the things which you can give to the patient. Okay, so coming on to just 1 second. Okay, so coming on to, if it is a chronic case, then what you will do? See, if it is a chronic case of pathological fracture, if it is a chronic case of pathological fracture, the yes, what is the definitive treatment for this? The definitive treatment for this turns out to be surgery. So Akiki Kalita, she says, where will you get the notes? Beta, this is the Telegram channel. This is the Telegram channel, Med Academy 7. Here you will provide, we'll provide the notes, Med Academy 7. But the important part which you have to understand is, please try and attend the class live and make your own notes, because एक तो जब आप लिखते हो तो आप याद करते हो, बोर्ड पे देखते हो तो आप याद करते हो, ठीक है, एंड यू विल एंड अप इन टाइम. ठीक है, जल्दी से आपका ये कंप्लीट भी हो जाएगा. ओके, देन अगेन, इफ इट्स अ ट्यूमर, देन व्हाट यू विल डू. ठीक है, अगर मान लो ये ट्यूमर है तो क्या करोगे? रिसेक्शन. ठीक है, सर्जिकल रिसेक्शन, कीमोथेरेपी, रेडियोथेरेपी, all these things can be done. So if it's a rickets case or if it's a osteomalacia, then what you will do? Then in these cases, you are going to start the vitamin D therapy. Okay, you will start the vitamin D therapy. Okay, okay. So now my good question, important question to all my good students. If I ask you this question, polyostotic fibrous dysplasia, you have to tell me which syndrome is associated with this. Polyostotic fibrous dysplasia is associated with which syndrome? Okay, with which syndrome polyostotic fibrous dysplasia is associated with? You know what? Your radiology faculty is also very fond of asking these questions. Okay, fine. So this was about the pathological fracture. ठीक है, अब pathological fracture, ठीक है, चलो इसका आंसर आप लोग कमेंट सेक्शन में देना. ठीक है, I'll wait for your answers in the comment section. Coming on to the next part and the third topic for today. तो अभी तक हम लोगों ने फ्रैक्चर टॉपिक डिस्कस कर लिया, पैथोलॉजिकल फ्रैक्चर टॉपिक डिस्कस कर लिया. थर्ड टॉपिक हम लोग जो डिस्कस करने वाले हैं वो है stages of fracture healing. Okay, stages of fracture healing. Stages of fracture healing. So stages of fracture healing में, ठीक है, आप मेरे साथ साथ डायग्राम बनाओ. And my request to editors, please don't cut this part where I'm making the diagram, because my students learn how to draw the diagrams also. Okay, तो देखो एग्जाम में भी क्या करना है आपने, इस तरीके का 5 लाइनें, आई मीन 5 टाइम्स ये सेम चीज आपको जो है ड्रॉ कर लेनी है इस तरीके से. एंड देन यू हैव गॉट फर्स्ट थिंग. सो फर्स्ट थिंग इज व्हाट? फर्स्ट थिंग इज एक्चुअली हेमेटोमा. ठीक है, तो सबसे पहले क्या होता है? सबसे पहले देयर इज अ हेमेटोमा formation. Okay, hematoma formation. So this is going to be the hematoma formation. So one is going to be hematoma formation, and next thing is going to be the necrosis. Understand? The necrosis of fracture ends. Okay, the ends which are fractured are going to be necrosed. So there will be necrosis of the fracture ends. Okay, necrosis of the fractured ends. Okay. In second, what is going to be there? There is going to be granulation tissue. In second part, there will be what? There will be granulation tissue that's going to be there, and this granulation tissue is going to have what? It's going to have deposits of some substances, and these substances are nothing but fibroblast and osteoblast. Okay, so these are what? Fibroblast and osteoblast. Okay, fibroblast and osteoblast. Okay, then you have got the after granulation tissue, what is going to be there? There will be, of course, hematoma. There will be, of course, granulation tissue, and there will be formation and deposition of some minerals also. Okay, so these are some minerals which are going to get deposited, and that's why this stage is called as callus formation. This is called as which formation? Callus formation. Now, these callus formation is of two types. One is going to be a hard callus, the other is going to be a soft callus. A hard callus and a soft callus. Okay, so both of these things are very important. A hard callus and soft callus formation. So you have got the granulation tissue in it, you have got the fibroblast, you have got the osteoblast in it with the deposition of minerals, and that is called as callus formation, the hard and the soft callus formation, and that is something which is radiologically seen. So because these are radiologically seen, now the orthopedic surgeon is going to tell you that don't worry, the healing is getting done. Healing is getting done. After that, you have got the lamellar bone formation. You have got the lamellar bone formation. So next part is going to be what? That's going to be lamellar bone formation. Lamellar bone formation. Okay, this is called as lamellar bone formation. And after that lamellar bone formation, you will have what? You will have, so lamellar bone formation is called as remodeling. Okay, it is called as what? It is called as remodeling. And in the end, you have got modeling. Okay, in the end, you have got what? It is called as modeling. It is called as what? It is called as modeling. So what do you mean by modeling? Modeling means, so modeling means what? So that the healed bone and the parent bone. So what do you mean by modeling? Modeling means so that the parent bone and the healed bone, parent bone and the healed bone becomes same. Now coming on to the MCQ part, the examiners are fond of asking this question now. Okay, tell the time duration. Okay, tell the time duration. So 1, 2, 3, 4, and 5. So what is the time duration? Just remember, very, very easy. So 1, 2, 4. Okay, so that's a song. 1, 2 ka 4, 4, 2 ka 1. Right? So 1, 2 ka 4, 4, 2 ka 1. My name is Lakhan. So 1 2 ka 4, 4 2 ka 1, what means? 1 means, yes, 1 means 1 week or even less than 1 week. 2 means 2 weeks. 4 means 4 weeks. 2 means 2 months. And then 1 nahi hai. This is many. M for many weeks. Why M? M for modeling and M for many weeks. So this is the stages of fracture healing. So this is the third question. Stages of fracture healing. So this was the third question. Stages of fracture healing. Coming on to the next part. Yes, coming on to the next part, that is complication of fracture. Okay, so coming on to the next part, that is next question, that is complication of the fracture. So this is the fourth topic of our discussion today, complication of fracture. Okay, so next important part is going to be complication of fracture. So we have discussed till now the fracture, the pathological fracture, and of course one more important part was the fracture, the types of fracture. Then we have discussed the pathological fracture. Now we are discussing these and we discussed the stages of healing, and now we are going to discuss the complication of fracture. Okay, complication of fracture. Yeah, so if we talk about the complication of fractures, see, you have to divide it like this. Okay, I'll make a table for you and we'll have to divide it like this, that we have got immediate complications, we have got early complications, and we have got late complications. And similarly, we have got systemic complications and local complications. Okay, so I know this would have been a very big topic or something like that, but I have intentionally tried and concised this in a very small table. Okay, so immediate, early and late, systemic and local, so these are important. So see, what is there in immediate complication? First of all, please understand shock. Why shock? Because there will be a blood vessel injury that is going to be there, so there will be a systemic shock which can be there. In early, understand, in early, what can be the cases? In early, we can have a mnemonic which is called as tie. So what is tie? Tie means E for early. Okay, and we have got T and I. So what is T? T for thrombus. T for what? T for thrombus. What is I? I for infection. I for infection. So thrombus as well as infection. So what is important in thrombus? In thrombus, you can have respiratory distress. In thrombus, you can have fat embolus syndrome, because whenever there is a fracture, of course, it can, the fat, fracture will cause the fat, and this fat can either go into the pulmonary vessels, and if it is going to go into the pulmonary vessels, it can even cause what? It can even cause respiratory distress. Okay, so one is respiratory distress, other is fat embolus, and third is deep vein thrombosis. And when we talk about the infection, so in infection, there can be septicemia, okay, there can be septicemia, there can be traumatic fever. Okay, so there is an entity which is called as traumatic fever. there can be crush syndrome as well. Okay, there can be crush syndrome as well. Okay, so what is crush syndrome? See, understand, if anything is getting crushed, of course that's going to be accumulated in a compartment. Okay, in a compartment, and in that compartment the pressure is going to increase. Compartment pressure is going to increase, and that is called as compartment syndrome, because the arteries, the veins, the nerves are going to get compressed there. So this is called as compartment syndrome, compartment disease, or compartment syndrome. Okay, coming on to the local complications. Now local complications means what? See, either immediate or any time, or even late, or even early, anywhere anything can happen. Injury, okay, injury and injury. So in all these things, injury is something that is going to occur, but depends now. Like for example, nerves are smaller structures. Okay, so nerves can be injured. Sorry, the nerves are smaller structures, so nerves can be injured even with a small hit also. Okay, so what happens in nerves and blood vessels? Like lately also they can get injured. Of course, they can get injured early, but lately also they can injured. So muscles lately can be injured, tendons can be injured. Okay, whereas joints, if injured, are early injured. If not injured, then not injured. Okay, like that. Viscera also. Okay, so like this you can remember. Okay, so these are the different complications of fracture which I have tried to sum up. Compartment syndrome is extremely important. Okay, these are actually important, compartment syndrome. So I'll try to cover compartment syndrome either today or in some other class. Of course, I'll take the compartment syndrome because that's an important topic. But now some students are asking for break. Okay, I'll give you break, but before going to break, let's understand about the late complications. So these are immediate, early, and late, and now I'll teach you about the late complications. Okay, the late complications. So what are the late complications? Say late complications, first of all, is going to be, and the most important is going to be, incomplete union of fracture. Okay, incomplete union of fracture. So if I talk about incomplete union of fracture, okay, if I talk about incomplete union of fracture, it can be a delayed union. Okay, it can be a delayed union, it can be a malunion, it can be a non-union, it can be a cross union. Okay, so delayed union means united but delayed. Malunion means but not united properly. This is again a very important short note, and we'll discuss. Okay, it is a short note. Non-union is also a short note. That means they both are not united. Non-union, and cross union means they have united to some other part. Okay, yeah. Then what are the other things? Yes, what are the other things? Yes, so other late complications can be. So other late complications can be OM. Okay, one is OM, other is MO. So what is OM and MO? So OM means osteomyelitis. Okay, osteomyelitis, that is the infection. What is MO? Myositis ossificans. Myositis ossificans. Now, what do you mean by myositis ossificans? It is the myositis. That means it is the inflammation of muscle. Myositis, as the name suggests, inflammation of muscles. Ossificans means when there is bone formation in the muscle. When there is bone formation in the muscle. Okay, when there is a bone formation in muscle, so this is going to be OMNMO. This is important. What can be the other things? Yes, other things can be stiffness. Okay, other things can be stiffness. Then now for example, if something is stiff, of course the blood supply is going to be decreased. Blood supply is going to be decreased, and then there will be what? There will be avascular necrosis. Avascular necrosis. Avascular necrosis. S for stiffness, S for shortening. Okay, S for stiffness and S for shortening is something that is going to be there, and shortening is also called as contracture. So you can remember ischemic contracture. Ischemic contracture. Okay, shortening and ischemic contracture, it is going to be there. And last but not the least, please remember osteoarthritis, because of fracture there can be inflammation which is going to be there for repair. So this is the osteoarthritis which can also occur in this. So immediate, early as well as late complications we discussed about the fracture. Okay, immediate, early and the late complications we have successfully discussed about this. Okay, so this is it for the complications part. Coming on to the next part now. Coming on to the next question now, and after the next question, I mean, yeah. So we have discussed all these things. Let me just show you the some pictures. Okay, one picture was there. I've shown you that picture. Okay. So now coming on to the okay, so fracture is something which we are done. All right. So now next topic which we'll be having for today. Yeah. So now it's the time for the next topic. Okay, 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 okay. Just give me 1 minute, dear students. Okay, so what we'll do, we'll just take a short break of like 5 minutes and then we will start the session again. So we will meet you at 5:20 p.m., right? We will meet you at 5:20 p.m. Okay, so a short little 5 minutes of a break. Okay, so yeah, we'll meet you at 5:20 p.m. now. Because I've got an important call. I'll just finish up this call and then will come. Okay. All right. So we are back, and I think audio video is fine.
Right. So we are back, and I think audio video.
Yeah, audio and video is everything is fine. So let's quickly start with the next important part now. The next important questions. Okay. And the very first important part is going to be the complications. So we'll discuss one by one the different complications because the last thing which we discussed was the complication only, and now we'll discuss about the delayed union and malunion. Okay, delayed union and malunion. Okay, so what is delayed union, what is malunion, how these are important, okay, and what you are supposed to write when it comes to an exam point of view. So this is delayed union as well as malunion. So I was having a good feature. Well, just let me check if I can use this feature or not. Yeah, correct, delayed union and malunion. Chalo ji. Chalo, now I'll use this feature. Okay, delayed union and malunion, the next question. So what are the definitions of delayed union and malunion? So delayed union definition says, okay, so first of all, the definition. So what is the definition of delayed union? So delayed union definition is when a fracture takes longer. Yeah, so when a fracture takes longer than expected duration. Okay, when a fracture takes longer than the expected duration, it is called as delayed. Okay, that is called as, yeah, but still there is potential for union. Okay, so delayed union is actually the fracture is going to take longer than expected duration, but still there is potential for union. This is called as delayed union. What is malunion? Sorry, my bad. Just one second. This is not delayed union and malunion. This is delayed union and non-union. Okay, these both topics are important. Okay, delayed union and non-union. Okay, these both the topics are important, and of course the malunion is also important. We'll discuss. Okay, now what is non-union? Non-union means when a fracture fails to unite completely. Now this line is itself very important because it is failing to unite completely. This line is extremely important. These are failing to unite completely, यानी कि थोड़ा भी अगर सपोज करो यूनियन हो रहा है बट कंप्लीट नहीं हो रहा, then also you will label it as non union. Okay, and shows no further and shows no further progress towards healing, okay, towards healing, then this is called as non-union, which is conventionally diagnosed, which is conventionally diagnosed after 6 months. So if the 6 months period has crossed, then you will call it as non-union. Then you will call it as what? Non-union. Now, after definition, the next part is the time, is the progress, is the we can differentiate on the basis of mobility, we can differentiate pain, and of course the outcome. ठीक है, so time means healing is slower, and this is diagnosed after 6 months. Then progress, yes, it happens, but there is no progress towards healing. Mobility, of course there will be a minimal mobility because the fracture is going to get unite. Okay, but here there will be an abnormal mobility that will be seen. There will be an abnormal mobility that will be seen. Pain, yes, the pain is going to be present, whereas the pain can may or may not be present in case of the non-union. And what about outcome? So outcome, it may unite. Okay, it may unite in this case, but this the in the non-union it is not going to, yes, it is not going to unite for sure. So what are the different causes of non-union and delayed union? Let's understand about the different causes of delayed union and non-union. So in the very first cause, the important cause is going to be what? That's going to be the related to the patient, then related to the fracture, and then related to the treatment. Okay, so related to the patient, related to the fracture, and related to the treatment modality, we can have different causes for what? Different causes for what? Different causes for your um, delayed union and non-union. So related to patient, like for example, if the age group is old, if there is a malnutrition which is there in the patient, okay, malnutrition may also have anemia in it, okay, then some systemic illness that is very common if if there is an old age patient, okay. So if from this old age you can remember the systemic illness like the diabetes mellitus, like the malignancy, okay. So yes, malignancy can be there. So all these things can be there, systemic illness, and then one more thing is going to be smoking. Okay, other important thing is going to be smoking. So old age, malunion, systemic illness, smoking, all these things are patient-related factors. Then what about fracture? So fracture, if so you can just make a diagram like this. Okay, yeah. So first of all, the blood supply. Okay, the blood supply is very important. So if the blood supply is not proper, of course, the healing is not going to be well in time. Then other thing is going to be excessive displacement. Okay, or commutation. You can remember. Okay, so if it is comminuted fracture, or if there is excessive displacement that has occurred. Okay, excessive displacement such that there is a soft tissue has came inside. So soft tissue interposition. Okay, soft tissue interposition. This is really important. Okay, next is going to be infection. Okay, and then if there is a continuously, like if it is a stress fracture, okay, if these are pathological fractures, of course the healings are going to be delayed. Okay, the healings is going to be delayed. Now, treatment issues can be there. Like, for example, some quacks, they are very famous to do the inadequate reduction. Okay, so if they are not doing the reduction properly, inadequate reduction, inadequate immobilization. Okay, inadequate reduction, inadequate immobilization. Okay, so all these things, inadequate fixation, if these things are not proper, of course delayed healing can be expected. Now coming on to the different types now. Okay, coming on to the different types of the delayed union, of the non-union. So one is going to be atropic. Okay, atropic, and the other is going to be hypertrophic. Okay, atrophic is going to be there, hypertrophic is going to be there. Now what do you mean by atrophic? Atrophic means, for example, there is no callus formation. Okay, if there is a no callus formation. Okay, so callus is not getting formed in this. Why? Because the biological activity is poor. Biological activity is poor. Like for example, if I talk about mineral deposition and all those things, so biological activity is poor and callus is not getting formed. So what is going to be there? Yes, what is going to be there? The fracture ends will be sclerosed. The fracture end will be sclerosed. Okay, where there will be sclerosis in this. And why it was atrophic? Because there was a poor blood supply. Okay, because the blood supply is poor, this is going to be atrophic. But what happens in hypertrophic? See, in hypertrophic, of course, the blood supply is going to be adequate. Okay, there is an adequate blood supply that is going to be there. That is why in hypertrophic there will be excessive callus which will be there. Okay, there will be an excessive callus that is going to be there in hypertrophic. Okay, and just remember what happens due to this excessive callus. There is mechanical instability. There is mechanical instability. So कहते हैं ना तो किसी चीज की कमी होनी चाहिए और ना ही कोई चीज ज्यादा होनी चाहिए. Because if it is more than required, of course it's going to create some of the other problem. Okay, so what are these sites? Now understand, types we have discussed, causes we have discussed. Now we will discuss about the different sites. What are the different sites which are responsible for delayed union or non-union? So just remember that some areas where the blood supply is creating the problem. Okay, so if the blood supply is creating the problem, the blood supply is problematic, of course the healing is going to be hampered. Okay, the healing is going to be what? It is going to be hampered. Okay, so for example, if I just talk to you about the, yeah, so upper part, if I talk about, so neck of femur. Okay, neck of femur. Lower part, if I talk about, lower third of tibia and lower third of ulna. Okay, lower third of tibia and lower third of ulna. Then other thing is lateral condyle of humerus. Lateral condyle of humerus. Okay, and one more bone is going to be scaphoid. Scaphoid. So just remember, this is very important MCQ also. Scaphoid is something that has been asked a lot of times, so it's for MCQ sake also, it is really important. Coming on to the clinical features. Now, for example, if there is a, there is a delayed union, or if it has not united properly, so what is going to happen? Because there is no union, the pain is going to be persistent. Okay, the pain is going to persist for a longer duration of time. So there is going to be a persistent pain that is going to be there. Okay, and in fact the pain on the stretching also, on the, or rather on the stressing. So if you will put some stress over the fracture site, so it is going to show you the pain. Okay, it is going to show you the pain. Okay, so one is this. Next is abnormal motility. This also abnormal mobility. This I have also explained to you. Okay, then limb shortening. Limb shortening. Now, why there is limb shortening? Because say for example, this was my original bone, and if it is getting fractured and the parts are going like this, so of course the size is getting shortened. Okay, the size is getting what? Shortened. So this is the limb shortening which is going to be there. And then failure to bear the weight. ठीक है, weight bear नहीं कर सकता, failure to bear the bear the weight. Coming on to the radiological investigations now. Okay, so radiological investigations, now we will discuss one by one. So what is important in radiological investigations? Of course the fracture line will be visible. Okay, of course the fracture line is going to be visible. Of course there will be inadequate or non or no callus that will be there. So in delayed union there will be inadequate, and in a non-union there will be no callus which is going to be there. Okay, especially if I talk about non-union, there will be sclerosed fracture end. Okay, there will be sclerosis of the fracture ends, there will be sclerosed fracture ends which are going to be there. And one important thing is there is obliteration of medullary canals. Okay, medullary canals are going to show you obliteration. Okay, obliteration is going to be there. Okay, so what is the treatment now? The final part in both these cases, what is going to be the final treatment, what you will give as the treatment? So please understand, if it's a delayed union, so you have to understand that it's a little delay. Okay, it's a delay which is going to be there. So we have to continue the conservative treatment. Okay, so continue the conservative treatment, जैसे कि painkillers we have to give, cold compression we have, warm compression we have to give. Okay, if you have applied some brace or some cast, just continue it. Okay, then immobilization has to be done. Okay, and then you have to underlying treat the underlying cause. Okay, underlying cause should have been treated. Then bone stimulation. So what do you do? Just stimulate the fracture ends, because if they will be stimulated, there will be better healing which is going to be there. And if there is no, still very much delayed, and you just want, so a little bone grafting can be done between the ends which are not uniting. Okay, and what will be the treatment of non-union? That entirely depends upon which type of non-union is there. So if it's an atrophic one, then it's going to be different. If it's hypertrophic one, then of course it's going to be different. So if it's an atrophic one, what you'll do? In atrophic one, please understand, give the internal fixation. internal fixation, plus you have to improve the stability also. Okay, you have to improve the stability as well. So internal fixation with the screws, with the plates, okay, with the nails, okay. So screws and you should write, sorry, plates and nails, okay, plates and nails. Whereas what about hypertrophic? In hypertrophic we have to again uh, okay, so sorry, I've written wrong. Internal fixation and stability improvement has to be done in hypertrophic, whereas internal fixation plus you have to add bone grafting, okay, because there is atrophy, so that's why we have to do the bone grafting in this. And in non-union we have seen a very good use of Elizaro's method. Okay, so of course Elizaro is an important thing. Elizaro's technique is an important part, so I'll teach you Elizaro, okay, in some subsequent lectures, or if I'll be able to take your instruments class, I'll surely teach you about the Elizaro's technique. Then electrical stimulation. Okay, then next is electrical stimulation. Okay, electrical stimulation. Next, excision and arthrodesis. Okay, excision and arthrodesis. Okay, these are done in the selected some selected cases only. But what is the complication? Yes, what is the complication of delayed union and non-union? Yes, what is the complication of delayed union and non-union? So in these cases, of course, there can be deformity, there can be pseudo-arthrosis as well. Now, what is pseudo-arthrosis? You guys will tell me in the comment section. Pseudo-arthrosis. So deformity, pseudo-arthrosis, refracture. Okay, there can be refracture also. So these things are really, really important. Okay, really, really important. So this is the delayed union or the non-union. Okay, delayed union or non-union. I guess I have some. So see, this is not this is not delayed union. This is not non-union. So what is this, Anji? What is this? Chalo, tell me quickly. Tell me what is this? Not delayed union, not the non-union. What is this? This is malunion. Okay, this is malunion. So can you see this is supposed to join here, this is supposed to join here properly, but they are not. So this is malunion. Okay, that's going to be their malunion. All right, so this is malunion. This is okay. Now what is this, bache? So can you see this is a fracture line? Yes, there is a fracture line which is there. And what is this? This is a radiolucent area. That means already some pathology is there, underlying some pathology is there. So fracture line in a radiolucent area tells you what? This is a pathological fracture. This is what? This is a pathological fracture. Okay, pathological fracture is going to be there. Coming on to this. Okay, now this is going to be the next topic of discussion. What is this? Anji, what is this? Can you see there's a fracture which is there? Anji, can you see there's a fracture, or if there is not, okay, I'm drawing this fracture line here. So this is my first metatarsal. I mean, this is the first metatarsal. That's going to be this is the second metatarsal. And if I can see the fracture in the second metatarsal fracture is something which is called as second metatarsal fracture is something which is called as March fracture. Okay, it is called as what? It is called as March fracture. So now we will discuss about the next topic of our discussion for today, that is the March fracture. So in the beginning of the lecture series, I showed you a clinical case in which I told you that an army man who is stressing on the limbs a lot while marching develops prolonged foot pain. Huh? Okay, so fracture on the second metatarsal. So, chalo. Now coming on to the fracture on the second metatarsal. Okay, I'm writing it here now. So let's discuss about the March fracture. Okay, let's discuss about the next fracture. This is called as March fracture. Okay, हाँ जी. So now March fracture. So what is important in that March fracture? Let's understand what is the definition of March fracture. So what is the definition of March fracture? So March fracture is the stress fracture. So first important point is the stress fracture. So March fracture is nothing but the stress fracture which is going to involve the neck of second metatarsal. Okay, second metatarsal. Now I have seen some books, they write the third metatarsal also, but actually it is the second metatarsal only. So stress fracture which involves the neck of the second metatarsal and the so you have to understand that what will be the clinical feature of this. So see, ultimately it's a fracture only, so the clinical features are going to be same, but like for example, if I write pain in March fracture, the pain is going to be on forefoot. So this is something that can give you some extra marks, because everybody is going to write pain, but you will write forefoot pain. Okay, the pain is going to get aggravated. Okay, the pain is going to get aggravated. How it is going to get aggravated? With activity, and it is going to get relieved or decreased with rest. So whenever you are going to rest, this pain is going to get relieved. Okay, and yes, there will be localized tenderness also. On which area? There will be localized tenderness on metatarsal area. Okay, there will be localized tenderness on metatarsal area. So what is the investigation you will do? Hanji, what is the investigation you will do? So the investigation taken care in this case is going to be X-ray. Okay, of course you will do X-ray in that case. And what this X-ray is going to show you, it shows fracture line or periosteal reaction. Okay, either there will be fracture line which will be seen, or there will be seen as the periosteal reaction. So what is periosteal reaction? So whenever there is a fracture, there is a periosteum which is actually very chui type. So whenever it is stimulated thodi si bhi, it is going to start showing some of the reaction. So what is going to be the treatment? So treatment is actually really very simple. Okay, treatment is very simple. So rest is actually the, okay, just one second. So rest is actually the mainstay of the treatment. Okay, then of course painkillers can be started. Then you can have the immobilization also, that's also important. Okay, then cold compression, or rather I should not use these words. Just limb elevation is something which is required. Okay, elevation of limb. So limb elevation is something which is required. Now the good part of this fracture is, this fracture is that the prognosis is excellent prognosis. Okay, the prognosis is actually excellent prognosis. Okay, and no surgical treatment is something which is required. Okay, no surgical treatment is required. Okay, so this is something that's really important, and I have written it for you. This is a small chotu sa topic, March fracture, and in your textbook of Maheshwari, which most of you are using, okay, in 21st chapter, they have also written very chotu sa box, okay, very small box, and then I've tried to still make it look like a short note, because I have seen this March fracture has been asked as a short note for in that case. Okay, so after March fracture, now coming on to the next important part, and the next important part is going to be what? It's going to be green stick fracture. Okay. So next important part is going to be what? It's the green stick fracture. So now we will discuss about the green stick fracture, and green stick fracture, again, it's a very important thing. So coming on to Yeah. So coming on to the green stick fracture, see, understand, in children, rather than, I should say, Maheshwari textbook clearly specifies that it is the fracture in the older age group children. So in old age group children, okay, and that's too in the shaft, okay, in the shaft area of the bone. Old age group children in the shaft area of the, okay, old age group children in shaft area of the bone, that's going to be the green stick fracture. That's going to be what? That's going to be the green stick fracture. Just give me 1 second. So Greenstick fracture is an incomplete fracture seen in children. Okay, let me start writing the definition of it. So it's an incomplete fracture seen in children in which bone bends and cracks on one side while the opposite cortex remains absolutely intact. So if I just try and draw the diagram, if this is the epiphysis, see this part has bent, this part has cracked, whereas this cortex is absolutely normal. This cortex is absolutely normal. So this is about the definition. Now, what are the etiologies and what are the causes? Okay. So what is the etiopathogenesis? So see, etiopathogenesis means, first of all, green stick fractures are going to occur because of the mild traumas, okay? Not the big traumas, just happens because of mild traumas, okay? Little milder traumas, okay? So, for example, fall on outstretched hand, foosh, okay? Fall on outstretched hand, okay? Then after that, you have got, so these are seen in children. Okay, so this is, now we will discuss about the pathogenesis. So these are children. Now, what happens in children? The children have softer bones. They have got highly elastic bones. Okay, they have got highly elastic bones are going to be there, and their bones are less mineralized. Okay, their bones are what? Their bones are less mineralized. So because they're softer bones, elastic bones, less mineralized bones, that's why what happens in them, there is going to be just the bending, and the crack is going to come only on the one side, where the other side is not going to show any crack or anything. Okay, so age group, of course, I've told you, like in 10 to 12 years. Okay, so now coming on to the clinical features. So clinical features, the very first thing, clinical feature, the age group. Okay, because you should know, first of all, that in 10 to 12 years of patients, it is something which is very, very much seen. Okay, now, of course, what is going to be the site? So generally, we have seen it is the radius and the ulna. Okay, the general is the radius and the ulna, which is actually most common, but of course, and yeah, this is an MCQ also. Okay, so it's important. And after that, we have to understand that even the tibia and the clavicle can also be involved. Okay, tibia and clavicle, but radius and ulna has to be understand. This is important, important, and important. Okay, so, so it's softer, it's highly elastic. I have told you. Okay, just remember it is less mineralized, and two more important thing is that it has got high, lot of collagen, so it is dense. ओके, डेंस एंड इलास्टिक ऑल्सो, इतना इलास्टिक होता है कि मोड़ा भी तो टूटेगा नहीं. आपने पेड़ की अगर टहनियां देखी हो, सो ओके, सो ठीक है, आई ड्रॉ दिस छोटू सा पेड़ फॉर यू सो दैट यू डोंट फॉरगेट ग्रीन स्टिक. ओके, आई जस्ट ट्राई एंड ड्रॉ दिस छोटू सा पेड़ फॉर यू, एंड दिस इज द ग्रीन स्टिक. ओके, यहाँ से ये ग्रीन स्टिक्स जो है ना, वैसे दिखेंगे आप लोगों को. सो ये ग्रीन स्टिक होती है, आप कितना भी इनको मोड़ लो, दे आर नॉट गोइंग टू, they're not going to crack. Okay, so there's a lot of collagen. Okay, and the periosteum is also very thick. Okay, which is going to give the protection. The periosteum is also very thick. Okay, the thick periosteum is going to be there. So clinical features, the age group we have discussed, the site we have discussed. The other feature, of course, the pain is going to be there, tenderness is going to be there, swelling is going to be there. Okay, these things are there in all the types of fractures. Okay, and yes, of course, there will be restricted movement, okay, at the fracture site. Okay, and the very important feature in all the pediatric patients is that they are going to cry like anything. Okay, they are going to cry like anything. After that, we have got the radiological Okay, we have got the radiological features now. So radiological features, just understand that again, the X-ray is something which is done, and what this X-ray is going to show you, the X-ray is going to show you the break in one side cortex. Okay, the break in one side cortex, and the other side is going to show bending. Okay, bending in the opposite side cortex, bending in the opposite side cortex. Now, good important part, everybody knows what to write in Greenstick fracture, but treatment part is again very important. So you have to understand that we do what? We do the closed reduction. Okay, we do what? We do the closed reduction in this case. We do closed reduction. Okay, um, and please don't forget to do immobilization with the POP cast, because it's a child. Okay, so POP cast is something which is applied for a period of over 3 to 4 weeks. Okay, so this is important. um Yes, green stick fractures might also show some or the other complications. And in the complications, please understand one important complication is malunion that's going to be there. Then it's going to be refracture that's going to be there. And in fact, there is going to be growth disturbances also. Okay, so malunion and refracture is something which you can understand. But yes, because there is no major fracture which has occurred, so we have seen that the prognosis in these cases are excellent prognosis, very good prognosis. Okay, rapid healing is going to be there. Okay, so this is it about the green stick fracture. So this is, I have tried and shown you about the green stick fracture. Of course, I'm going to have a good image of the green stick fracture as well. I'm just trying to see if it is there or not. Yes, green stick fracture. So this is malunion. Okay, so can you see the it has not united properly? It is what? It is the malunion. I'll discuss with you malunion also. Yeah, see this important X-ray, very important X-ray. See this, this is really important X-ray. You can see the fracture line, fracture line on one end. You can see the bend also, which is going to be there. So if there is bending and the fracture line is there on one end, this is something which we call it as the hari chhadi fracture, green stick fracture. Okay, hari chhadi fracture, green stick fracture. Okay, so this is important, green stick fracture, right? So again, these are really important. So now coming on to the next part, the next important thing, that is malunion. Okay, so our today's discussion was more on, actually it is more on the fracture and its related things. Okay, so now we'll discuss about the next part, and that is called as malunion. Yeah. So coming on to the malunion now. So again, malunion, another topic, important topic for us. Okay. Really very important. So malunion means what? Malunion means when the two fragments are not, are not joining in a proper, this thing, proper, I should say, proper manner. Okay. So by definition, what is malunion? Yes. By definition, what is malunion? Just 1 second. Yes. So definition wise, malunion is a condition in which fracture unites, in which a fracture unites in improper, or it unites in a faulty position. Okay, it unites in is in an improper or a faulty position. Okay, resulting. Okay, which resulting in deformity or resulting in functional impairment. Okay, so fracture unites fracture is going to unite, but in an improper or a faulty position that results in some other deformity or the functional impairment. Yani ki either anatomy is going to be at fault, so anatomical deformity, or there is a functional problem, that is functional impairment, that is going to be there. So this is the definition. This is what? This is the definition. After that, if I just, put a note and just try to explain it to you that, malunion we use, we use this term when there is a clinically significant deformity. Okay, so just remember clinically significant. Okay, I think I should not write here. So improper or faulty position unites in improper and faulty position which is clinically significant. देखो, हर हर यूनियन के बाद में, हर यूनियन में थोड़ा तो माल यूनियन होगा ही होगा, but if it's a clinically significant thing, then only we call it as a, mal union. Then only we call it as what? Then only we'll call it as a mal union. Coming on to the causes now. Okay, so what are the different causes of mal union? So one is going to be improper treatment. Okay, so one is going to be what? That's going to be an improper treatment. One is improper treatment. Then other is uncontrolled muscle pull. So one fragment is going to be pulled. Okay. Then excessive comminution. Excessive comminution. Excessive comminution can be there. So improper treatment. So sorry. Improper treatment is going to be there. Uncontrolled muscle pull is going to be there, and excessive comminution can be there. So what you have to understand is that, what is the most common one? So most common one is the improper treatment. So most common one is going to be improper treatment. What happens in uncontrolled muscle pull? Like for example, you have seen Colles fracture, especially, and the clavicle fracture. Okay, clavicle fracture, Colles fracture, they have got uncontrolled muscle pull and excessive combination. मतलब चूरा चूरा हो गया हड्डी का, तो naturally वो जुड़ेगी, तो there will be some malunion which is normal to be expected. Coming on to, yes, coming on to the types of deformity. Okay, so types of deformity, तो किस तरीके से जुड़ेगी, तो वो I mean अगर खराब भी जुड़ रही है, so what is the type of deformity? So in the type of deformity, please understand, either it can be an angular deformity, तो जुड़ रही है at some angles, angular deformity. There can be rotational deformity, ऐसे rotation करके जुड़ रही है, rotational deformity. Shortening, एक दूसरे के ऊपर चढ़ गई, so there will be shortening, there will be overriding of the two fragment of the bones. Okay, and then there will be translational deformity. There will be translational deformity. Okay, translational deformity. So angular, rotational, shortening, and translational deformity, these are the types of deformity which is going to be there. Coming on to clinical feature, देखो, एक हिंदी में कहावत होती है, प्रत्यक्ष को प्रमाण की क्या जरूरत है. सो क्लिनिकल फीचर्स हो चाहे ना हो, आपको दिख ही जाएगा, आपको दिख ही जाएगा. ठीक है, सो फर्स्ट क्लिनिकल फीचर इन दिस केस इज द विजिबल डिफॉर्मिटी. Okay, that's going to be what? There is going to be, so sorry, in clinical features there's going to be what? There's going to be visible deformity which is there. Okay, there is a visible deformity which is there, and yes, if it is overriding, then there will be shortening of the limb. ठीक है, यदि वो एक overriding है, so then there will be shortening of the limb which is going to be there. Okay, then of course क्या movements वहां पे हो पाएंगी? No, बिल्कुल भी नहीं हो पाएंगी. There will be, there will be limitation of the movements. Okay, then next important part, of course there will be cosmetic deformity also. ठीक है, cosmetically भी वो आपको इतना अच्छा नहीं दिखेगा. There will be cosmetic deformity as well. ठीक है, इसी से रिलेटेड ही हमारी कुछ ना कुछ कॉम्प्लिकेशंस भी होती हैं. ओके इसी से रिलेटेड हमारी कुछ ना कुछ कॉम्प्लिकेशंस भी होती हैं। कॉम्प्लिकेशंस क्या क्या हो सकती हैं? वन इज गोइंग टू बी द रिस्ट्रिक्टेड जॉइंट मूवमेंट, कि भाई इतना ज्यादा खराब यूनियन हुआ है कि जॉइंट ही मूव नहीं कर पा रहा, रिस्ट्रिक्टेड जॉइंट मूवमेंट। देन और क्या हो सकता है? डीजेनरेशन ऑफ एडजेसेंट स्ट्रक्चर्स, ठीक है, डीजेनरेशन ऑफ एडजेसेंट स्ट्रक्चर्स कैन बी देयर, like the nerve can be degenerated, like the vessels can be degenerated, okay, all these things. After that, the last but not the least is going to be the treatment part. And in treatment, see, whenever you have a malunion, the first treatment you have to understand that sometimes we don't require any treatment, no treatment is required. Sometimes we required operative treatment, so sometimes we need an operation, operative treatment is going to be there. And sometimes, you know uh, yeah, so no treatment and operative treatment. So no treatment is there, is required if it's a mild malunion. If it is not clinically significant, then there is no treatment which is required. Okay, and it is especially seen in children. Okay, like for example, in children, what happens that there is, there is already a good bone remodeling. Okay, so in children there is a good bone remodeling which is there. So we practically saying we don't need any kind of treatment in them in the children, so bone remodeling. Coming on to the operative treatment, so what operative treatment is? So one operative treatment is something which is called as osteoclasis. Okay, osteoclasis is something which is first treatment, osteoclasis. So what is osteoclasis? So osteoclasis means refracturing the bone. Okay, or osteoclasis means what? So in osteoclasis we do the refracturing of the bone. Okay, so you refracture the bone, and once the bone is refractured, okay, it's going to unite properly. It is generally done in the case of children. So just remember C for classes and C for children. So this is osteoclasis. Then surgical correction. Okay, surgical correction. So in what do we do when we, okay, what do you mean by surgical correction? In surgical correction, what we do? So fracture site is exposed, and after exposing the fracture site, we correct the malunion, and after the correction of malunion we will do internal fixation with plates and nails. Okay, and we can even do bone grafting if it is required. So if bone grafting is required, we can do this surgical correction. Okay, and corrective osteotomy. Next part, next important thing, corrective osteotomy. Okay, so corrective osteotomy. So what actually corrective osteotomy is slightly different from the surgical correction, because corrective osteotomy is done far from the fracture site. Okay, it is done far from the site of fracture, because fracture site is not suitable, might be infected. Coming on to the last part, that is excision of protruding bone. Okay, so sometimes we have to do the excision of the protruding bone as well. Okay, excision of the protruding bone, which is very commonly done if it is clavicle. Okay, if it is clavicle, we generally do this. Okay, so this is all about the malunion. Just one last point I would like to mention it here, that if it is a, if we check for the prognosis, so in prognosis, just remember it is very good if it is case of children. Okay, but in adults it is variable. Okay, it is variable depending upon the conditions. Okay, depending upon the severity, depending upon the conditions. So I mean severity and corrections. Okay, like that we have to check. Okay, so this was about the malunion. So today's topics were actually these topics: the malunion, then greenstick fracture, march fracture, then you have got the delayed union, non-union, and the fracture healing. Okay, I'll change this. Just 1 second. Stages of fracture healing. Yes. The other topic of discussion was your pathological fractures. Again, important part. Yes. Then you were having the types of fracture and fracture, right? So this was the very first topic which we started with. Yeah. Okay. So fracture and the yeah. So these things are actually the common things which which was planned for the session. But I can see that there are one or two things which I want to incorporate in today's lecture itself. Just give me 1 minute. Um, yeah. So one is sequestrum and other is the. Okay, I'll write this. So now two topics are remaining. One is something which we will start with, sequestrum, and the other topic that is remaining for today is the compartment syndrome. Okay, so sequestrum and compartment syndrome. Compartment syndrome can be taken with the supracondylar fracture also, but I think because compartment syndrome is a complication of fracture, so I'll take in this part only. So these are important things which we will start after coming back from a chotu sa short sa little break. Okay, and this is I think 6:10. Okay, so we will meet at 6:15 p.m. Okay, we'll meet at 6:15 p.m. and then we'll have lecture till 7 or 7:15 and then we will finish up today's class, right? Yeah. Okay. All right. So welcome back, and I think audio videos.
Alright. So welcome back.
All right. चलो जी, ऑडियो भी ठीक है जी, वीडियो भी ठीक है जी. चलो अब हम पढ़ेंगे नेक्स्ट टॉपिक जिसका नाम है फैट एम्बोलिज्म. ओके, कंपार्टमेंट सिंड्रोम. ये वाले टॉपिक जो हैं अब हम लोग को डिस्कस करने हैं. जस्ट गिव मी 1 मिनट. 1 मिनट दे दो बस, एंड देन वी स्टार्ट. चलो बच्चे, सो अभी हमने क्या करना है. जो कॉम्प्लिकेशन ऑफ फ्रैक्चर्स थे ना, तो कॉम्प्लिकेशन ऑफ फ्रैक्चर में हमारे पास में 2-3 और टॉपिक्स भी थे, जैसे कि ऑफ कोर्स कंपार्टमेंट सिंड्रोम और फैट एम्बोलिज्म जो है, ये बहुत ज्यादा इंपॉर्टेंट टॉपिक्स हैं. तो एक बार हम इनको डिस्कस करते हैं, लास्ट में फिर हम लोग सिक्वेस्ट्रम डिस्कस करेंगे. ठीक है. सो क्विकली स्टार्टिंग विद द टॉपिक ऑफ फैट एम्बोलिज्म नाउ. So what is fat embolism? And in order to understand about the fat embolism, we'll have to go through. तो इसमें क्वेश्चन कैसे पूछा जाता है? So you'll have a history of patient underwent some surgery. Okay, underwent a hip replacement surgery, and now complaining of sudden breathlessness. Okay, so what can be the diagnosis? Then of course, if the diagnosis you know, then of course they can ask you to tell you about the definition, tell you about the etiology. Then they'll ask you to write about the pathology, then classification, and then yes, what more? Then the clinical features, the radiological investigations, and in the end, they will ask you to write about the management also. And one criteria, that's the GERDS criteria, is something that is oftenly asked from the fat embolism also. GERDS criteria in the fat embolism. ठीक है. तो ये सारी चीजें जो है वो पूछी जाएंगी, ये सारी चीजें जो है हम लोगों को करना है. आई एम सो सॉरी. Sorry. Yes, okay. So now coming on to the very first part, the definition of your Hanji, definition of fat embolism. So what do you mean by fat embolism? What is the definition? So definition, acha, before definition, let me just tell you about the classification a little bit here only, because then only we will be able to understand fat embolism in a better situation. So if I talk about the classification of this fat embolism, you have got three very important things. One is going to be subclinical. ठीक है, या तो वो सब क्लिनिकल हो सकता है जहां पर सीधी सी बात है क्लिनिकल फीचर्स नहीं होंगे, सब क्लिनिकल. ठीक है. या फिर वो नॉन फल्मिनेंट हो सकता है. ओके, इट कैन बी नॉन फल्मिनेंट और इट कैन बी फल्मिनेंट. Subclinical, non-fulminant, and fulminant. If I talk about the non-fulminant, that means clinical features are going to be present, but there will be non-severe. Whereas in fulminant, there will be present and there are going to be severe. Okay, so is present as well as severe, it is going to be. Okay, so what is the definition? So as the history, I have told you, in the history point of view, the definition becomes very easy. The definition says that it is an acute respiratory disorder. It is an acute respiratory disorder due to inflammatory response or due to inflammation or inflammatory response to embolus of fat globules. Embolus of fat globules. Okay, so this is the important definition you should remember. Very important definition. Acute respiratory disorder due to inflammatory response to the embolus of the fat globules. Okay, all right. Chal. Coming on to can be the different causes for this. So what are the different causes, or what is the etiology for this? So if I talk for the etiological basis of fat embolism, it can be because of trauma. So one, it can be traumatic, and the other thing, it can be non-traumatic. So I belong to northern India, and the very beautiful city over here is Chandigarh, which we write it as CHD, Chandigarh. Okay, and then traumatic. So where the maximum trauma occurs, at the border security force. So border security force in Chandigarh. This is how you can remember. So what is B? B for burns. What is S? S for surgery, surgical history, like the total hip replacement. Then what is F? F for fractures. Then what is CHD? Now C for collision vascular diseases. Okay, so collision vascular diseases. Then what is H? H for hemoglobinopathies. Hemoglobinopathies. What is D? Diabetes mellitus. So these are the different etiological factors which are there. Coming on to pathophysiology. Coming on to pathophysiology. So if I talk about the pathophysiology, we have got three theories. One is called as mechanical theory, other is called as biochemical theory, and the third one is called as metabolic theory. So what is mechanical theory? Mechanical theory says if there is a trauma, because mechanical means trauma, mechanical means something mechanical, trauma. If there is trauma, there will be release of fat globules, and because there is release of fat globules, they are going to enter into the venules. This is the mechanical theory. Whereas biochemical theory, so T for trauma, T for triglycerides. So biochemical theory says that if there are triglycerides, they are going to yield free fatty acids, and these free fatty acids can even go to lung parenchyma. Okay, lung parenchyma. Okay, and from where these triglycerides are coming? From the fat of the bone. Okay, so bones are going to have this yellow fat and everything. What about metabolic? So metabolic theory believes that there are some hormonal changes which are going to occur, and because of these hormonal changes, there will be the release of free fatty acid, and that is going to get absorbed by the chylomicrons. So chylomicrons will be formed in the will be there in the blood. Okay, so this is how we can remember about them. Coming on to the clinical features. Okay, coming on to the clinical features of acute of your fat embolism syndrome. So in clinical features, just remember that there is an important triad of cardiopulmonary problems. So one is going to be the cardiopulmonary dysfunction, cardiopulmonary dysfunction, cutaneous changes, and neurological dysfunction. Neurological dysfunction. So what is going to be there in cardiopulmonary dysfunction? This is the earliest of all the manifestations. That's why you will have very important three things. Either there will be tachycardia. Why? Because see, this is the heart. These are the lungs, and if the lungs are not getting proper supply, the heart will try to beat more so that it can supply the blood. So there will be tachycardia, there will be tachycardia, tachypnea, hypoxemia. Okay, tachycardia, tachypnea, and hypoxemia. What about cutaneous changes? So cutaneous changes, it shows rash in the oral region or in the conjunctiva. What about neurological dysfunction? There can be hemiplegia if the embolus enters the brain. There can be seizures also, and there can be Pusch's retinopathy. Pusch's retinopathy. Now, what do you mean by Pusch's retinopathy? Pusch's retinopathy is nothing but retinal damage. It is the retinal damage. Okay, retinal damage. Okay, it is the retinal damage. Coming on to GERD's criteria. So, keeping in mind all these things, let's understand about the criteria now. This is the GERD's criteria. So, GERD's criteria says that we require one major and four minor criterias. Okay, one major criteria out of brain involvement, out of lung involvement, out of rashes. And in lung involvement, they specify that if the respiratory PaO2 is less than 60 mm per Hg, 60 mm of Hg, then it is turned out to be respiratory insufficiency. But if we talk about four minor criteria, there we have tachycardia, fever, retina changes, renal changes. So R for retina, R for renal change, R for rate. Which rate? Anji, which rate? Electrocyte sedimentation rate. So ESR is going to be there. Fat, this is erythrocyte sedimentation rate. Fat microglobulinemia. So tachy, fever, fat, RRR. F for fever, F for fat is going to be there. Okay. Coming on to what will be the radiological signs. Coming on to what will be the radiological signs which you are going to see. Okay. So if I talk for the radiological sign, first of all, if we check for the chest X-ray is going to show you pulmonary infiltrates. Okay. Chest X-ray shows you pulmonary infiltrates. Then we have got CT scan. CT scan shows you ground glass appearance. And then comes the MRI brain. MRI brain. So chest X-ray, CT scan, and MRI brain. Okay. Now, important thing which you have to understand is, now see, normally what happens in the alveoli, there's going to be air, and air is actually black in color. Okay. But for example, if there is, let's say, the fat, okay, the fat has a, and this is the artery. Okay. Now, since this artery is having the embolus in it, of course, the excessive fluid is going to come out. The fluid is going to come out and the fluid will go inside these alveoli. So these in place of air will show white opacities, and these white opacities look like a snowstorm appearance. It looks like what? It looks like a snowstorm appearance. Okay, it looks like what? It looks like a snowstorm appearance, and that is why it is very essential to perform the ECG also, because it is going to show some heart changes as well. How will you manage the case? So if I talk about the management of fat embolism, please remember important point: ABC, airway, breathing, circulation. Okay. And since the heart is at risk, okay, this is airway, breathing, circulation. And since the heart is at risk, we have to do the blood transfusion, or I think we should be ready for the blood transfusion if not necessary. Next, of course, there's fracture and there's a risk of embolus. So please immobilize the patient. Immobilize the patient. Give antibiotics. Give analgesics. Okay. Also give prophylaxis for DVT. because it can even cause deep vein thrombosis. Okay, deep vein thrombosis. Now, understand, heart I have told you, and every time we talk about heart, it was cardiopulmonary. Okay, it was cardiopulmonary. So pulmonary is again important. So we have to maintain the PEEP and give the mechanical ventilation. Maintain the PEEP and give the mechanical ventilation. Okay, and medical therapy has to be started. We have to give the prophylaxis of DVT. You can give the heparin also. You have to give the dextran also. Then give the your steroids have to be given to decrease the inflammation. Heparin and dextran, what does they do? Dextran is a plasma expander, so increasing the plasma volume. And what about heparin? It is a lipolytic, so it can do the lysis of the embolus which has been formed. Okay, and coming on to the last but not the least, that's the prevention part. So what has to be done in prevention? Please do the early stabilization. That's really important. So you have to stabilize the patient early. Do the early stabilization. Okay, and there is something which is called as reamer irrigation aspirator. So that has to be taken care of. Okay, irrigation and aspiration has to be done properly. Now coming on to the next part, the last second topic of today's discussion, that is the compartment syndrome. Again, a complication of fracture. Okay, so now let's discuss about the compartment syndrome, and then we will discuss about the sequestrum part. So how do they ask the compartment syndrome? So they will give you a history, like okay, so they'll give you a history, like history of a local practitioner. Okay, and a very tight cast. Okay, was applied to the patient, and after that the patient felt numbness. Okay, the patient felt pain on stretching. Okay, and pain otherwise also. There was pulselessness which was there. Okay, there was pale skin that was seen. So you have to understand that they are trying to ask you about the compartment syndrome, and of course then they will ask you some allied questions. So what are the different allied questions they are going to ask you? They will ask you about the definition, for sure. They will ask you about the etiology, the definition, etio- etiology, pathophysiology, clinical features, investigations, treatment part, and in the end, complications. Okay. One important thing which I will add as a surplus note over here, that is the tissue survival. Okay, I'll teach you about the tissue survival as well. Okay. So, okay. So just a quick feedback time. So the people who have joined, are you guys enjoying? So that I can do my little evening snacks also. Chaliye. Coming on to the definition. So by definition, compartment syndrome is so first of all, you should understand what is compartment. So compartment is a closed area having blood vessels, having nerves, having muscles. Blood vessels, nerves, and muscles. And remember, this is a compartment. And because this is a compartment, you have to understand that the normal pressure. So the good part of compartment syndrome is that everything starts with the letter P. Okay, everything starts with the letter P. So normal pressure here is starting from P. Either it is 15 maximum, 5 lowest. So 5 to 15 mm of Hg is the compartment, normal compartment pressure which is there. Okay. Then what is compartment syndrome now? So what is compartment syndrome? So it is the elevated pressure. Understand? It is the elevated pressure of osteofacial canal. Because of course here you will have fascia also, here you will have the vessels, the arteries, the veins, the nerves. Okay. So compartment syndrome is elevated pressure of osteofacial canal, okay, that causes microvascular compromise and affects the tissue viability. And so I was telling you about the etiological factors. One is compartment size decrease or the content is increase. So if the compartment size is decreased, this is actually the most common cause, and that is either you have applied a tight cast or you have applied a tight cast or you have applied a tight tourniquet. These both are the factors responsible for decreasing the size of compartment, whereas content increase means all the contents. Like for example, you see, the fracture. First of all, the compartment has got bone, so fracture. So most common cause is going to be fracture of tibia or fracture of forearm. Fracture of tibia or fracture of forearm. Then there can be soft tissue swelling that is going to be there. Then there will be vessels which are going to show, some coagulation deformities as well. Okay, coagulation issues as well. For example, in snake bite also, what happens in the compartment pressure is going to increase a lot. Then there can be some fluid infusion as well. There can be some fluid infusion also. Okay, from where the fluid is coming, like for example, from arthroscopic fluid is coming. Okay, arthroscopic fluid is coming like that. So this is the content increase. Coming on to the next part, that is called as pathophysiology. So in pathophysiology otherwise is self-understood, and I have nothing to teach you in detail about pathophysiology. But what is important is the name of the cycle. So there is a cycle which is called as Eaton and Green cycle. So there is a cycle which is called as Eaton and Green cycle. Okay, so Eaton and Green cycle, this is important cycle. Now what is there in Eaton Green cycle? See, understand, if the artery is compressed. Okay, first of all I should say if the veins, because veins are delicate, they are going to get compressed earlier. So if the veins are compressed, they are going to have what? They are going to have the fluid leak. So if they are going to have fluid leak, that causes artery compression. So if the arteries are going to get compressed, that leads to ischemia. And if there is ischemia, that causes cell death. And if there is cell death, that causes edema. If there is edema, that causes increase in the compartment pressure. And again, coming on to the veins are compressed. Okay. So this is the Eaton and Green cycle, which you should know. Okay. Eaton and Green cycle. And in pathophysiology, there's a very good formula to understand that local blood flow is equal to pressure of arteries minus pressure of veins by vascular resistance. Okay, pressure of arteries minus pressure of veins by vascular resistance. Now what is important in this? Just remember that whenever the vascular resistance is increased, the local blood flow is going to be decreased, and this is what happens in compartment syndrome. Okay, so that's why it's very important to classify. I've told you either classification that can be fulminant, non-fulminant. Okay, so I think this I've already explained this. Okay, that's more of a fat embolism classification. Coming on to the classification of compartment syndrome. Coming on to the classification of compartment syndrome. So either it can be an acute one or it can be a chronic one. So if it is an acute case, so in acute case, please remember it's a nothing but a medical emergency. Okay, acute case, nothing but a medical emergency. And chronic, okay, so chronic, you have, exertional compartment syndrome. Now what do you mean by exertional? So if there is exertion, of course there will be more ischemia and cell death and edema, all these things are going to be there. So this is called as exertional compartment syndrome, whereas acute one is a medical emergency. So you have to do what? You have to do fasciotomy. Okay, you have to do what? You have to do fasciotomy in this case, right? So this is about the classification. Okay, now just wanted to show you this. For example, this is the muscle and this is the nerve which is coming and incorporating this. So just remember only this thing, that both of them till 8 hours it is a irreversible injury. Okay, till 8 hours it's an irreversible injury, and sorry, till 8 hours it's reversible, but after 8 hours it's going to be an irreversible injury. Okay, irreversible injury, right? So yeah. Now, what are going to be the different? I should say, what are going to be the different things? Okay, different clinical features which you are going to have. Okay, so clinical feature, if we talk about, then we can have every feature. So I write compartment as COMPARTMENT, compartment, like this. Okay, why? Because you will have pain, you will have paresthesia, you will have paralysis, you will have pain on passive stretching, you will have pallor, you will have pulselessness, and on palpation there is going to be a palpably tense compartment. Palpably what? Palpably tense compartment is going to be there. Okay, yeah. Now after that, pediatrics. Understand what happens in pediatric age group? Just one second. I don't know why it is creating some issue. So what happens in pediatrics age group? In pediatrics age group, they show variable amount of anxiety. Okay, pediatric age group shows variable amount of anxiety, agitation, as well as analgesia. Okay, so high analgesia, that means there's a lot of pain, so the perception of pain is also increased. Analgesia, high analgesia, that's going to be there in these patients. Okay, in pediatric age group. So what investigations are you going to perform? What investigations are you going to perform? So when it comes to investigations, you will do what? You will do the best is actually, yeah. So these are the MCQ points also. What is best? What does X-ray is going to show you? Okay. So just remember, the best is going to be clinical. Okay. The best is going to be clinical. In X-ray, you will have fracture. Okay. And then there is something which is called as compartment pressure monitoring. Okay, there is something which is called as compartment pressure monitoring. Yeah, compartment pressure monitoring is something that is done. Okay, that is something which is done. So basically what happens in this, so you have got a mercury manometer. Okay, so you will have this is a mercury manometer, and in mercury manometer you will have a tube which is connected over there. This is manometer showing the pressure. This is a tube which is going to be connected, and it will further be connected with a piston, and further it will be connected to the compartment. Okay, so for example, the pressure difference here is X and pressure difference here is Y. So basically the saline flow, when you will put the saline over here, the flow of saline is directly proportional to X minus Y, where Y should be less than 15 mm of Hg, and this is how we do the compartment pressure monitoring. Okay, we do the compartment pressure monitoring. So what is going to be the investigation? So in investigation, just remember, first of all, if the patient is hypotensive, understand, if the patient is hypotensive, you maintain the hemodynamics. Okay, you maintain what? You have to maintain the hemodynamics. And what's next? See, if there is yeah. So should we do leg raises in these patients or not? Very important question, a star mark question. Leg raises in these patients should not be done. Why? Because when you raise the legs, the arterial supply is going to be further decrease. Okay. The arterial supply is further going to decrease. That's why in compartment syndrome, please don't do the leg raises. Again, hemodynamics has to maintain the airway, maintain the breathing, maintain the circulation, and remove the cast. Okay, so whatever the problem is there, we have to remove it. And in emergency cases, yeah, so what you have to do in emergency cases, what you're supposed to do in emergency cases, you have to do fasciotomy. Okay, you have to do what? You have to do fasciotomy. And what is going to be there in fasciotomy? So fasciotomy is of two types. One is Mastine's fasciotomy and Mubarak's fasciotomy. Just remember the names, nothing more than that. Okay. Next is, if some necrotic tissue is there, then you have to do debridement for this necrotic tissue. Okay, do debridement for this necrotic tissue. And the other part is vacuum assisted, you can do. And then you have got coverage, so cover it. Okay, skin grafts can be used for coverage. Okay, skin grafts can be used for what? It can be used for coverage. Now what can be the complication, further complications of compartment syndrome? So complications, further complications can be Waxman ischemic contract. So the mnemonic is actually, okay, I'll write the mnemonic. Mnemonic says save. So V for Waxman ischemic contracture. Waxman ischemic contracture. Then S for sensory loss. A for amputation. E for equinus. Okay, equinus means they will have the claw toes, claw toes. Okay, so these are the things, these are the complications which are going to occur of the compartment syndrome. Okay, of what? Of the compartment syndrome. Coming on to the last topic for today, that is called as sequestrum. Okay, the last topic for today, that's called as sequestrum. Okay, so just give me 1 second. I'm a little occupied. I'm so sorry for this, but there's an urgent OTP which has come to me. Yeah. So now sequestrum. So what is sequestrum? Yes, what is sequestrum? Sequestrum, first of all, definition of sequestrum. Definition of sequestrum is that it is a segment of dead necrotic bone separated from living bone, separated from living bone due to loss of blood supply, due to loss of blood supply, which is most commonly seen in chronic osteomyelitis. So when we will discuss chronic osteomyelitis, I'll ask you this: what is a dead necrotic bone which is separated from a living bone? Okay, so this is a which is a sequestrum. Okay, so sequestrum. So sequestra itself means, okay, sequestra itself means to separate. Okay, sequestra itself means to separate. Okay, sequestra means separate. So what happens? Let's understand about the etiopathogenesis. So as I've told you that it is most commonly seen in where? It is most commonly seen in osteomyelitis. So whenever there is going to be trauma, whenever there is going to be infection, okay, what is going to happen in case of trauma and infection? It is responsible for causing the vascular thrombosis. Okay, it is responsible for vascular thrombus or thrombosis that can cause the infection, that can cause the ischemia, and whenever there is ischemia, that causes bone necrosis. And whenever there is a bone necrosis, the dead bone is going to separate from the living bone, and that is called as separation of dead bone from living bone, and that is something which is called as sequestra formation. Okay, sequestra formation. So most common primary, most common, understand, most common primary etiology is going to be the chronic osteomyelitis, chronic pyogenic osteomyelitis. So let me just write down chronic pyogenic osteomyelitis. Yes, but what can be the other causes? So other causes, of course, can be open fractures. Yes, it can be open fracture. It can be your post-operative infections. Okay, even radiation injuries. ठीक है? So basically infection, open fracture, that means you are connected to the external environment, and that's why this is important, because the mnemonic becomes RICE. Rice becomes the mnemonic. Okay, rice becomes the mnemonic, right? So now you have to understand this, that what is the most common if like causative organisms in pyogenic osteomyelitis itself. See, the most common cause, okay, let me just write down, the most common cause of chronic osteomyelitis is acute osteomyelitis. Okay, chronic osteomyelitis का जो most common cause है वो क्या है? Acute osteomyelitis है. And just remember, staph aureus is the most common cause of acute osteomyelitis. Okay, most common cause of acute osteomyelitis is going to be Staph aureus. Okay, Staph aureus. Coming on to which is the most common bone or most common site. So now we are entering about the clinical features. So in clinical features, what is the most common site? So just remember that tibia is the most common site for sequestrum formation. Very, 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 very important. Now, how does sequestrum appear? What is the gross appearance of sequestrum? So in gross, please understand that it's going to be hard, it's going to be dry, it's going to be ivory white, it's going to be yellow. Okay, so hard, dry, ivory white, yellow. This is the bone piece grossly. Whereas if you will see in the microscope, okay, if you will see in the microscopy, it will appear as empty lacuna. There's going to be empty lacuna, that means absence of osteocytes. Empty lacuna, that means absence of osteocytes is going to be there. Okay, then there is going to be surrounding granulation tissue. Why there will be surrounding granulation tissue? Because of course there is a chronic inflammation, and granulation tissue is a sign of chronic inflammation for sure. Okay, right? समझ में आ गया? Great. Coming on to the clinical features. So again, the clinical features will be very similar to what? Very similar to your chronic inflammation, chronic osteomyelitis. That means there will be chronic pain, there will be chronic swelling, there will be redness, okay, recurrent discharging sinus, okay. Although the sinuses are the clinical features of acute osteomyelitis, but recurrent, when it comes, it becomes chronic, okay. Then fever, then tenderness, okay. All these things are going to be there, okay. All these things are going to be there. Now, it can even have some systemic effects as well. It can even, so for example, if there is a chronic bone issue, if there is a chronic bone issue, what is going to be there? There can be anemia, which can be there, okay. There can be anemia, there can be growth retardation in children, okay, right? ये सारी चीजें जो है ये हो सकती हैं. So how to see them? Yes, what is the investigation modality? So investigation modality is going to be nothing but X-ray itself. X-ray में ही जो है ना आप लोगों को पता लग जाएगा. But please remember, X-ray may be normal initially. Okay, X-ray may be normal initially. ठीक है, इनिशियली हो सकता है कि एक्सरे जो है वो नॉर्मल आए, बट बाद में इट कैन शो यू द डेंस रेडियो ओपेक, हाँ जी, डेंस रेडियो ओपेक डेड बोन फ्रैगमेंट, ठीक है, बोन फ्रैगमेंट विच इज surrounded by radiolucent granulation tissue. ओके, राइट. तो ये आप लोगों को पता होना चाहिए. ओके, बट यू नो sometimes we have seen CT scan is also good. Why? To identify the shape, to identify the size, to identify the location of sequestrum. CT scan is again very important. Okay, right, clear, good. So sequestrum, just remember that naturally, I should say that it acts as a persistent focus of infection. Okay, so just remember, just note it down that it acts as, so sequestrum is nothing but a persistent foci or focus of infection. It's a persistent focus of infection. Okay, so just remember that treatment, now coming on to the treatment is not something which is regularly done. So if you see the sequestrum, you say chalo treat karte hain. No, it is not regularly done. Sequestrum treatment is not something which is regularly required. But for example, so what are the indications of doing the treatment? If you are having a persistent infection, okay, if there is a persistent infection which is there, or you have sinus formation, if there is pain which is there, okay, sinus formation is there, pain which is there, in all these cases we have to take care of the treatment. So what is the medical management and surgical management? So very simple, very medical management, and then you have got the surgical management. Because see, I've told you it's nothing else but a focus of what? A focus of infection. Now, because it is a focus of infection, so you have to do culture guided antibiotic therapy. Okay, culture guided antibiotic therapy is something which we have to do. And surgical management is sequestrectomy. That means remove the sequestrum. Sequestrectomy is something which is generally recommended. Coming on to the last part, last discussion. Okay, last second discussion. What are the different? Wait for some time. if that issue is resolved. Okay. Issue was there, so it is resolved now. Okay, so type of sequestrum. One, there can be a tubular. Okay, so this is a tube now. So this is tubular, and this tubular tube has got this O, right? This O is there. So this O is for what? This O is for osteomyelitis. Which osteomyelitis? Again, acute pyogenic osteomyelitis. Acute pyogenic osteomyelitis is going to be there. Okay, acute osteomyelitis. Yeah. Now, for example, this would have been a limb. Okay, just 1 second. Yeah. ठीक है. सो नाउ फॉर एग्जांपल दिस वाज अ लिम्ब. सो अगर ये लिम्ब होता तो देखो यहाँ पर हम लोगों ने रिंग बना दिया. ठीक है, यहाँ हमने रिंग बना दी, यानी कि रिंग सिक्वेस्ट्रम से आपको क्या याद रखना है कि ये एम्प्यूटेशन में दिखती है. रिंग सिक्वेस्ट्रम इज समथिंग दैट इज सीन इन एम्प्यूटेशन. रिंग सिक्वेस्ट्रम इज समथिंग व्हिच इज सीन इन एम्प्यूटेशन. ओके, या फिर स्टेनमैन्स पिन. फॉर एग्जांपल यहाँ मैंने पिन डाल रखी है, तो यहाँ पे क्या बनेगी? रिंग बनेगी ना. So this is also Steinman's pin. Steinman's pin के आजू बाजू भी कैसा सिक्वेस्ट्रम बनता है? रिंग सिक्वेस्ट्रम बनता है. रिंग सिक्वेस्ट्रम इज गोइंग टू बी देयर. ठीक है. आइवरी. ओके, आइवरी. आइवरी मतलब क्या होता है? ऐसे दांत. ठीक है, हाथी के दांत मैंने बना दिए. आइवरी. ओके, सो आइवरी सिक्वेस्ट्रम किस में दिखता है आपको? सिफिलिस में दिखता है. सो आइवरी इज सिफिलिस. ये देखो एल एल है ना, बड़े बड़े दो एल एल. तो ये दो एल एल को इस तरीके से समझो, ऐसे ऐसे. ठीक है. सो आइवरी इज बीइंग विद द syphilis. ठीक है. then we have got fine sandy. Okay, fine sandy. So for example there is a person whose name is Sandeep. Okay, and Sandeep is just a virus. Okay, थे ना एक वीरू सहस्त्र बुद्धे. हाँ, सो याद रखो कि वीरू सहस्त्र बुद्धे का नाम क्या है? संदीप. So remember sandy, fine sandy is seen in what? Virus. Okay, so in viral, remember this, in viral osteomyelitis you will have fine sandy. Okay, fine sandy. Okay, sandy is fine, whereas coarse. Okay, अभी संदीप का क्या करा दिया गया? सीटी स्कैन करा दिया गया. दैट मींस कोर्स सैंडी इज समथिंग दैट इज सीन इन ट्यूबरक्यूलोसिस. ओके, कोर्स सैंडी इज समथिंग व्हिच इज सीन इन ट्यूबरक्यूलोसिस. ओके, राइट. या, एंड फॉर एग्जांपल अभी टीबी में ही एक और भी दिखता है जिसका नाम है फेदरी. ओके, जिसका नाम है क्या? फेदरी. सो जस्ट रिमेंबर लाइक दिस दैट दिस फेदर. ओके, दिस फेदर
Hello, check. 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 Okay. Only 5 minutes of lecture is remaining. हाँ वो मैं कर लेता हूँ.
All right, beta. All right. Just 1 second. Yeah, so I just hope that everything is fine now.
Yeah, so I just.
So, guys, in the comment section, we have Dr. Sankal. He is my mentor, a very, very brilliant surgeon, and a very, very, very super talented surgery faculty as well. So, if any day you get a chance to study from him, he's a legend, definitely a legend. And thank you so much, sir, for always motivating us and motivating our children as well. So, guys, we were discussing about the sequestrum now. So I think I've covered most of the part of the type of sequestrum. With this diagram, I'll just try to, recapitulate it for you. For example, ये मान लो एक ये ट्यूब है और ये ट्यूब में ये O है, O से ऑस्टियोमाइलिटिस, एक्यूट पाइथेनिक ऑस्टियोमाइलिटिस. उसके बाद में हम लोग रिंग सिक्वेस्ट्रम की बात करते हैं. तो फॉर एग्जाम्पल जैसे हमने किसी का पैर काटा तो यहाँ पर ये रिंग बन गई. सो दिस इज अ रिंग एम्पुटेशन. ओके. एंड दूसरा मैंने आपको कहा था कि स्टीनमैन स्पिन. ठीक है, तो ये किसी के माथे के ऊपर ऐसे समझ लो कि हमने दो आंखें लगाई हैं, स्टीनमैन स्पिन लगाई है, ये एक आई, ये दूसरी आई. आंखों के बाद में फिर हमने उसकी दो मूछे बनाई हैं. मूछे जस्ट लाइक आइवरी, एंड आइवरी sequestrum is seen in syphilis, so double L just looks like the ivory, two ivory teeth. Then I have told you kissing is seen in TB. And who is the one who is kissing? This is Sandeep, and Sandeep was the name of Viru Sastra Buddhe, the virus. So just remember Sandy virus Sandeep, and viral osteomyelitis. And इस संदीप का क्या कराना पड़ेगा हमें? CT scan कराना पड़ेगा. Course Sandy is also seen in the tuberculosis, and this tuberculosis is written like this TB. Okay, this is written like this TB. So ये जो ये T और B है, ये एक हैट है जो हमने इसके सिर पे डाल दी है, एंड ये हैट के ऊपर में फेदर्स लगे हुए हैं, यानी कि टीबी इज आल्सो गोइंग टू हैव द फेदरी काइंड ऑफ सिक्वेस्ट्रम एज वेल. अब ये इनका मुंह बनाया है, सो मुंह से हर कोई क्या लगाता है? दो घुट पिला दे साथिया, बाकी मेरे पे डोल दे. ठीक है, सो दिस इज द बॉटल ऑफ मिल्क, है ना? So this is Coke. So remember, Coke shaped sequestrum, C for Coke and C for cancellous bone. Okay, C for Coke and C for cancellous bone. ठीक है, cancellous bone sequestrum जो होता है वहां पर Coke shaped sequestrum बनता है. कहां पर? cancellous bone के अंदर. ठीक है, चलो अब उसके बाद में याद रखो ये C हो गया, और ये C के पास ही मैं लिख देता हूँ B. सो B से क्या है? B से होता है बॉम्बे और ब्लैक. ठीक है, बॉम्बे सिक्वेस्ट्रम बोलते हो या फिर ब्लैक सिक्वेस्ट्रम बोलते हो. किसमें दिखता है आपको? व्हेन देयर इज अ लॉट ऑफ H2S, अ लॉट ऑफ पोल्यूशन. ठीक है, तो आइडियली इट शुड बी कॉल्ड एज दिल्ली. हाँ, दिल्ली सिक्वेस्ट्रम, लेकिन चलो इट इज कॉल्ड एज बॉम्बे. Okay, anyways, black sequestrum. Black sequestrum is also seen in, okay, black sequestrum is also seen in a black fungus, and that fungus is called as actinomycetes. Okay, actinomycetes. Okay, actinomycetes के अंदर में भी ये दिखता है, actinomycosis के अंदर में. And last part, okay, so देखो ये एक होता है साला और एक होता है जीजा. Okay, साला जीजा. साला कौन होगा? सैल्मन भाई, साल्मोनेला. And Jija से याद रखो G. G means what? It is having a granular sequestrum. It is having what sequestrum? It is going to have a granular sequestrum. Okay, granular sequestrum. So this is it for today's class. Okay, so we have discussed all the important topics. I sincerely thank you for from the bottom of my heart for attending this lecture. And tomorrow we will start in the morning 10 a.m. Okay, so morning timings for tomorrow is going to be 10 a.m. Okay, so we will meet in tomorrow's class. Tomorrow we'll start at 10 a.m. because in the evening, right, we have some other commitments. So yeah, so we will have to look at it. Okay, for tomorrow 10 a.m. in the morning we will meet. Okay, so thank you so much and God bless you, beta.